Okay, so thanks again. We are here in the lab 4 now. We just finished a case in lab 1, and now it's my pleasure to introduce to you Ricardo Costa. He's going to be the first operator for this also challenging case. And Alberto Cervoni, who has been working with us for such a long time now, about 5 or 6 years.
Yeah.
Is that correct, if you count the fellowship program?
Okay.
And also we have the chief of our CAT lab, Dr. Sergio Braga, who is our professor here. He's just to be with us. Ricardo, you're going to present the occasion without any uh, extra time. Let's go further,
Okay,
please.
thank you, Fausto. So we have a case of 47-year-old female patient. As clinical presentation, she has presented with stable angina, now CCS2, but I have to say it's evolving over time and it's compromising to some extent her quality of life. As comorbidities, she has history of hypertension, dyslipidemia. Here, the current medication she's taking, so she's under antiplatelet therapy plus medication to control her hypertension, enalapril, carvedilol to also help with the symptoms, amlodipine, hydrochlorothiazide as diuretic, and simvastatin. As a lab test, nothing that calls the attention, has a normal renal function and a normal LV function with a previous transthoracic echocardiogram. Here, her EKG at rest, we don't see any significant abnormalities. And she was referred for a diagnostic angiogram. This is prior to coming to our
She's
institution.
only 47 years old.
Only 47
We
years
just
old.
treat a lady in the other room with a 61. How come the young ladies are coming with coronary artery disease?
Yeah, we're seeing this every time more. It has to do perhaps with the more exposure to risk factors. In female patients, this has been a lot of studies now focused on women, and unfortunately, we are seeing these patients evolve with significant coronary artery disease and also acute events in a very relatively early phase.
Okay, she still have hormones and a period. She
Yeah,
has period or not?
she's still, yeah, she's not in menopause yet.
Non-menopause
Yeah,
yet.
yeah,
47 years old.
yeah.
So very young, very
So,
young.
yeah. So she was referred for a diagnostic angiogram, as I mentioned, was done in another institution. It calls attention already some degree of calcification, proximal LED. There's a mild to moderate disease in the first OM branch, and there's some
When was this
haziness.
diagnosis was performed?
1 month ago,
1 month ago.
yeah,
Was performed here?
in
No,
another institution,
another
another
institution.
institution,
Okay.
and there's some haziness at the very ostium
Yeah.
of the LED. That's a place where the calcium. You see here a tight stenosis at the very ostium location. It doesn't appear to involve the circumflex. It doesn't appear to involve the ostium and the proximal circumflex as well, and left main.
Yes, Ricardo, by angel, do you think there is some disease in the left main or not?
Yeah, it's interesting because if you see the very ostium of the left main is larger than the left main at the level of the bifurcation.
Okay.
So I suggest maybe there's some disease, but not significant by angel.
So, but we have a bifurcation lesion here.
We have, by definition, a bifurcation
Okay.
lesion. You
So
could
how
call
do you classify this?
by the median will be 0, 1, 0,
0, 1,
considering
0.
LED the main vessel.
Okay,
Okay,
great. Next.
so here we have the RAO. I would say the OM is a moderate lesion. We didn't think it was very significant. Here you see the LED.
Okay.
LED is also a vessel with mild disease. There's the calcification there. Oops, just go back
So
here.
how do you classify the calcification in this case by angel? It's
By angel-
mild, moderate, or severe?
I would say moderate because you can already trace the vessel without the dye.
Okay.
Okay.
And
Here,
then,
a LAO cranial view. So we cannot see the lesion well here. And the RCA, it's
so the catheter is very well intubated.
yeah, look like a, yeah,
I hate that.
yeah.
When we are doing a cath, we don't like to put the catheter. Is that correct?
Yes.
So we cannot just intubate everything. just go there because you can cause
Yeah.
some
It's
spasm.
very
Yeah.
dangerous.
Fortunately, did not perform it here because
Yeah.
we like to be perfect to do
Yeah.
also the diagnosed catheter.
Yeah.
It's very important
Yeah.
to keep the catheter just in the beginning of the artery.
Yeah. We try to teach our fellows this is very important because
Yeah.
you can cause a dissection, you can cause
Yes,
major
spasm
problems here. Spasm.
and misleading some lesion. Is that
Exactly.
correct?
Yeah.
Okay.
And then give a wrong diagnostic
Mm-hmm.
here, diagnosis.
Wrong diagnosis.
And another view.
Uh-huh.
So just
Small
irregularities, some mild
artery.
disease,
Okay.
not such a large
Uh-huh.
RCA as well. So if you could summarize, Fausto, this is a single vessel disease. OM branch, but moderate, but significant lesion, proximal LED, also the LED involving the left main. So by definition, we consider this a left main bifurcation, as you mentioned. So we also had some scores here.
Uh-huh.
It's a low syntax score.
Okay.
So
But before they score, why don't you indicate surgery for this lady?
Yeah.
Internal memory, low risk. So she's 47 years old.
Yeah.
Should we do that or not?
That's a possibility. Definitely, you
But
can.
you need to open the chest.
You can open the chest, have a lima here,
That's the problem.
but it's much more invasive procedure.
Yes. Yes.
And with the development of these techniques, the technology, we are seeing very comparable results
Okay.
in a situation like this between
This is
surgery
a
and
very,
PCI.
This is a very young lady, and we don't want to open the chest with a big incision, a large incision in the chest. So he's only 47 years old. So if you can treat it at least in the similar way, maybe we can choose a
Yeah,
percutaneous
we
coronary
believe that too.
intervention.
Yes.
I agree. I totally agree with you. So
And-
you're talking about syntax score. Do we
Yeah.
need to do syntax score in a case like this?
Yeah, we don't need, but it's good to say that both Syntax 1 and Syntax 2 recommend either PCI or cabbage. So the two, based on this recommendation, the two are okay.
But
And
syntax 1 is not only for multivessel disease.
it was validated for multivessel and or left main. So here as a left main lesion,
Okay.
we can use this score as well.
Okay.
And with the precise depth or the risk score for bleeding, she's a low risk of bleeding,
Okay,
so
good.
we feel
She's low
comfortable
risk for
on approaching
everything.
this patient.
Anatomic, clinical, and everything.
Yeah.
She's only 47 years old. So, what have you done so far?
Okay, so if you could have the angio, please. So here's the angio. We can see first the
So,
REO
what kind
caudal
of
view.
guiding catheter did you choose?
We choose a EBU 7 French to have a better support. Always when you're
Why do
dealing
you
with the left
choose?
main.
I saw you choose a femoral artery. Why do you not?
Yeah,
use
she did the
a-
first angiogram by radio, and the radio didn't have a good patency anymore.
Okay.
That can happen in 5%
So that can
of
happen with the
cases.
small ladies, small
Small
arms.
ladies, exactly.
When you punch the radio, sometimes you can have occlusion
Yeah.
of this artery. Is
Exactly.
that
It's a
correct?
predictor,
Okay,
yes.
good.
So that's why we're here and with 7 French. So we see, I have to say, the lesion in the ostial of the is not as bad as we saw in the angiogram here. In this first angiogram, here in the cranial view, you see the calcification there. You see the distal
For
LED.
this view, the lesion seems to me is less severe than the diagnosis.
Looks like less severe, more moderate lesion. Here,
Oh, yeah.
maybe a little bit worse here. Okay. It really, and
Did
we
you
have to
inject
say,
did you
this is a
inject
very critical location. If
Did you
something
inject
happens
nitro?
here, we did have nitro before.
Uh-huh.
Okay, so I would say here by angio, I quantify 70%, very ostial. If you take the distal
I would say a
LED,
little bit less. Can you go back a little bit? Let's do some explanation here. Okay.
Okay.
So
and
I would say 50, 55, before less than 60.
okay,
So does she have any stress test or?
she didn't have a stress test. She's only on optimized medical therapy and with worsening symptoms now, but it's a stable angina. This is the case.
Should we do FFR?
Also, it's always possible. It's a very proximal LAD, but this patient has symptoms. So she's
Yeah,
already,
but young lady, usually they have symptoms.
yeah.
They
And-
have some chest pain.
Yeah.
For this lesion, I don't know. Did you do IVUS?
We did imaging, okay?
Okay, let's see what
So-
you found.
And we didn't see the OM branch here as a significant lesion as well, okay? So now, if you could have the IVUS, please. Could we have the IVUS in the screen?
We are bringing the IVUS. Okay.
IVUS.
Okay, great.
Okay, so
Can you start the run, please?
just start the run. So just one moment. We started here at the second diagonal branch. Just to put into perspective, this is in the mid portion of the LED. So please start it. You see here at 7 o'clock, that's the diagonal.
Let's see.
Just run. No, no, just run. Okay, just run. Okay. Okay. So here we are between the diagonal and the septal, which looks like to be a relatively good landing zone. We're going to start to see uh, coming the septal branch now. And that's where the disease becomes to be more important. It's a calcified about 90 to 180 degrees. That's mild to moderate disease at this point. There's some degree of calcification. Here, this is in between the septal and the first diagonal branch. That you see some mild disease by angio. You see here the let's say mild compromise of the lumen, the calcification. Here could be another landing zone. We just saw the diagonal here coming at 7. It's always good to have the landmarks. And here also, that's where you see the most significant lesion coming. Okay, calcified. This is a very awesome of the LED. And you can see the wire here coming from the circumflex. Okay, and if you could stop here, please. Just move to the where is 6, please. We just move a little bit here.
So did you calculate the area?
Just brought back here, so the very ostial location, okay?
Okay.
And that's a circumflex coming. So the tightest point is a very, very ostial location. So can you stop and just go?
Can you stop the ostium?
Just go one by one. So here we are at the level of the second diagonal mid LED. Next one. You see the vessel here is about 3 by 2, 3 by 3 lumen actually. Next one. Here's where you see the level of the septal. You see a tighter stenosis than you see by angio is calcified here. Next. Here you can see the proximal diagonal. Next. Here, the ostial location about 3.1 millimeter square. So this is the minimum lumen area at the very ostium of the LED. Next. Here you can see how the plaque extends into the left main. So we see the plaque does not end at the ostium of the LED. It ends at the left main, which is very common. Most of the cases are like that. Next. See, now we are coming one by one here in the proximal LED, in the left main. Next, just the plaque extend. And this is the left main. The distal portion of the left main is about 4.5. Next. And the proximal portion of the left main is about 5 millimeters square.
Okay, good. I have a suggestion here to you, if you agree or not. So we have, you said 70, 60. You told us she has some stable angina. She's only 47 years old. She has some disease in the left main. I think you cannot just place a stent in the LED. So if you do a procedure here involving left main, you have a chance of 20% of MACE in 4 or 5 years. Do you agree with this?
Absolutely. That's what the data says.
The data says. So why can you just take a look in the physiological way, just to do a very nice demonstration? I mean, they have not prepared this, but we can do that because it is live.
That's awesome. That's precision PCI.
Okay, and to try a correlation with the area by IVUS and also. Do you agree with this?
Yes.
Physiological assessment. Do you?
Yeah.
So let's do that.
Absolutely. Let's do that. Yeah.
Can you open the catheter, prepare for physiological? So I think it's important. We are not here just to place a stent. Ricardo he's a professor, he's a teacher how to treat bifurcation. Actually, we had a very nice meeting last week here in Brazil, organized by Ricardo. We called the Bifurcation Summit with Antonio Colombo being with us. It was a spectacular meeting. And only studying bifurcation during 2 days. And now we have a bifurcation lesion here at the lab. But I think we need to clarify if the lesion is important and if it
Não,
needs
é
to be treated.
refiro.
Because after you
Deixa a
place a stent,
adenosina, dilui 2 para
that
18, tá?
means you're going to give
2 para 18.
DAPT. You,
Tá.
you may have a complication here, even in very good hands and very safe hands, very experienced hands. And I think we need to demonstrate if you need to be treated. I know this lady has stable angina. She brought a diagnosed catheter with some lesion in the ostium of LAD. That seems to me about between 50 to 60%. It's not severe, and there is some disease in the left main. And I think we need to prove with physiology. If it's the physiology is okay, it means the prognosis for her is going to be good. And the stable angina maybe is atypical chest pain. I mean, I have seen many ladies with this kind of symptoms, and
vira
there
pra
is
cá, por
no
favor, pra gente
severe
acompanhar.
coronary artery disease. Wow, you were here. Okay. Can I change my gloves? 8.
So we just put in here. So
Okay.
this is a guide wire, okay, that we can do.
You have different system. What kind of system you are going to use?
This is a St. Jude medical system. Okay. This has been the FFR has been validated, mostly validated, but we can also do the non-hyperemic measure as well, and that's what we like to do in practice. So we don't have to do adenosine to all the patient. When there's some controversy, we can use either way.
Okay, good.
But we want to do first the non-hyperemic, and then we take from there.
Okay, great.
So we're just setting up the system here.
That's going to be a good demonstration. We are going to calibrate the machine and everything.
Ok, so we're just gonna zero here. Wagner, zero aqui primeiro. Zero, por favor, no
Alberto, you want to
polígrafo.
say some?
Zero polígrafo,
I
por
think
favor.
it's a good decision to do
Zero
some
polígrafo.
physiology
Espera,
because it's
Wagner,
a
zero.
really young patient. So it will be really good for her.
Ok, zero aí também, Wagner.
I think we feel better.
Yeah.
You know, we are in the right way. Yes.
Ok, so we just zero the system here.
There's
Liga aí, por favor,
one
para procurar.
piece of information and a piece of decision, I would say, that's very important. We cannot do unnecessary procedures.
Here.
We are fighting unnecessary procedures because makes the patient's life worse. You make the population's life worse too because you are going to spend more money and unnecessary money for that patient. So someone is going to pay for this. If it's unnecessary, we are going to share between all of us this amount of money. So we try to teach our fellows and everybody here, and we need to treat only if we have data. We cannot treat only moderate lesions and lesions that is not provoking ischemia or even symptoms. And sometimes we spend a little bit more money with the guide wire in the FFR system, but we can save one stent and have the patient just to be followed. So Ricardo is just get a good curve to get across that. If you can show Ricardo hands, please. Ricardo hands, and also his advice. So you need to calibrate the system when you bring the wire.
So I'm proceeding here with the wire.
Okay. Now we're going to have the angel. Ricardo is advanced the system there. We have two wires, one in the LAD and one in the circ. Are you going to keep the both over there?
Yeah, you can keep the wire in the circumflex, but I'm going to remove the wire in the LED once we
Maybe you
cross.
can just keep the wire in the LAD because it's going to be easier to you for being working of this.
Yeah.
And bring the wire back after you have the FFR wire in there. I think the guide wire needs to be the guiding cat needs to be a little bit engaged, Ricardo.
Yeah, it's a tough angulation there. So when
so
we
try
first
to do an unclockwise to go to LAD with the guiding catheter.
we're just
Good.
here in the LED.
Now the guide wire, the FFR guide wire is going through the lesions, and also it's the proximal part.
So we're
It's
gonna
getting the diagonal branch over there.
we're gonna remove now the
guide
wire
wire.
from the LED, okay?
LED.
And the circ we can keep there. That's not a problem to keep the circ there.
So, do you think
So-
this is a good position to be working with the LED?
Yeah, we're gonna now
Okay.
move to the crane. Just
Can
went
you
in the
bring
LED.
the reference here, please?
Yeah. So I'm removing here the
reference.
wire
Can you do that?
Yeah.
For him.
from the LED.
Okay.
Ricardo, can you take care
Okay.
of the...
And now we're gonna do the
What?
the equalization,
Okay.
which is thus in position. Just gonna pick
Equalization. That's a
the catheter a little bit out
good
here.
word. But you're bringing the wire just to put just to the LED.
Just to do equalization here.
The equalization.
Yeah. Maybe okay.
Can you have
Equalize.
the FFR system on the screen? Are they disconnected?
So it's well equalized. Now we're gonna
Cranial,
go
okay.
cranial. Yeah, cranial.
Wagner, tá conectado isso aí com eles? Não.
Let me change
May you have the
reference.
FFR in the screen, please?
May I change the... That's okay.
Tem certeza, Wagner?
Baixinho, por favor.
Now we move the views just to be in the LAO view. I think we are in the diagonal there or in the LED? LED.
I think it's diagonal here
Diagonal,
first.
we need to be a
Just gonna have a test
just,
here. Okay.
before over there. Okay, good. Now we have the septum. The guide wire is getting through. Distal
Test.
LED.
Test.
Okay, great. Are
It's
you
important
able
to go as
have
distal
the
as possible
FFR
here.
monitor in the screen? If not,
Test.
maybe you can bring the camera and just show here.
Maybe
If
it's
you look
now
at
enough.
my hand here,
So Fausto, I think we are in
Yeah,
a
we're
very
distal.
good position, very
may you have
distal.
the whole room, please? Can you look at me here? Hello? Right here. Wow. Okay. Can you see us
Qual
in
tridio?
the lab?
Silvio, qual tridio?
Can you bring the camera, please? And Ricardo is gonna do.
Esse é o tridio, Silvio?
This
So
okay.
I think we are in a good position. Can we see the FFR here? Can the camera show the screen here, please?
Yes, I'm asking the camera.
I'll do
Can you
some
bring this
intro.
camera here? Excuse me, this camera here
On top.
on top.
Yeah, we are.
Top camera. No? Can you hear us? Pode baixar aqui para mim? Baixa aqui um pouquinho isso aqui para mim. Aqui, um pouquinho a
Can I
coisa.
do the night nitro?
Não, o microfone.
Faz rapidinho.
Aí. Are you hearing us?
Bom.
I mean, the
Sure.
backup support. Okay, can you bring the FFR monitor to the big screen? Is that possible? Okay, great. Thank you so much. Thank you so much. It's perfect.
Okay, so we just gave here nitro.
Uh-huh.
It's good to wait a little bit before we do the measure. Just wait a little bit because we just did the nitro. 30 seconds. So we are in a very distal position. We take all the myocardium at risk here in this anterior territory based on this
Can you
ostial lesion.
can you bring it back, the guy wire?
Yeah,
I
we can
think
do
it's
the
okay.
pullback too.
Pull back.
Yeah, I think.
Because
Okay.
I think the tip of the wire is a little bit distal.
Yeah, we can
Then we would
pull
like
a little
to.
bit.
Okay?
Okay.
So the guiding catheter position should be engaged to the coronary artery or in the aorta?
Should be just at the ostium if
At
you
the
don't have
ostium.
a disease left main.
Okay.
And I think we are in a good position here.
You are in a good position now?
We pulled back a little bit, yeah,
Okay.
from where we were before. Okay, so let's do the measure. So we do the non-hyperemic RFR from St. Jude. So it's 0.83. This is quite below the cutoff, which is about 0.89
Okay.
and below. It's always good to repeat this measure.
It's important, see?
Okay, let's do it again.
So we are measuring again.
The same position. Okay, so 0.85. If you have some doubt about the variation, you can do it again. That's not a problem. Live again, live. This is very easy to use, straightforward. Okay, next one. Okay, 0.86.
So you have three measures: 183, 185, 86.
Yeah.
Do you think it's easily positive?
I think it's
Yeah.
quite positive.
Positive.
But we can do the pullback
Okay.
as well,
Let's
just
do.
to show if it's confined to that lesion or if that's a segment
Okay.
with a significant disease. So, okay, so we have a feature here for the pullback, okay? Go on. So I'm pulling back here the wire, okay?
Okay. Pulling back the wire. What can you measure over there now? At
You
this
do
point?
see some degrees here. It's measuring already.
No. Okay.
And now I'm bringing here, I'm just passing the lesion. Okay? So we can stop. So here, Fausto, we can interpret this in a way that there is some, let's say, diffuse disease
Yeah.
that compromises to some extent the physiology alteration here. But the largest degree here is at the very proximal lesion. So if you consider the territory as a whole, you'd have, that consideration that you can cause ischemia based on that.
Can you measure over there?
Yeah, well, that's you have to see that. You cannot measure one by one. But can you show that, Wagner?
I thought the guide wire was too distal. How about if you leave the guide wire in the mid portion of LAD and do the measure? Do you know what I mean?
Yeah, we can
you
do
do
that,
that?
but there's a recommendation to be in the very distal because you're taking all the territory, but we can do that too.
Just to make sure if you okay.
So I'm just advancing here.
Yeah, okay.
I have the transducer just across the lesion. Okay.
Let's do the measure now. Great.
Let's start again.
Let's do the measure now. .92.
So it's 0.92. Let's do it again.
92.
Yeah,
93.
93. But the thing here is you're not taking the full coronary bed into consideration. You're taking
But
only
you
the
were
proximal.
looking at the particular lesion here.
Yeah. You're taking the lesion, you're taking that component of the lesion, but you're not taking the full coronary bed. This is, I would say, this is a situation that you can take this to help your decision. You don't have to decide based on a number. This patient has stable coronary disease. It's about 3.1 IVUS. The measure, it's positive for ischemia for the full anterior territory, but you do have some diffuse disease that impacts this measure as well. So this is something that can be and should be taken into consideration as well.
Okay. So how do you make your decision?
Yeah, Dr. Fausto.
Alberto.
The recommendation is to put the wire as distal as you can put without.
So to see all the coronary.
Yeah, you have to see all the myocardial at risk.
But you're not gonna treat all the LAD.
But
you're gonna treat only the proximal.
Yeah, the 0.93 tells us that we can win like 7 points of physiology. If Wagner, can you show us again the pullback? No, the pullback. The pullback. So no. Yeah, the pullback. If we add 7 to that number, we will have like 9.3.
Okay.
So it will be negative now. If we treat,
No significant
if we
ischemia.
treat that lesion, we will have a negative place to.
Okay. So if you treat that lesion, you're gonna be negative.
You're gonna negative.
Yeah.
For
So
the
the
anterior
patient will have
territory.
no ischemia after all.
So you think we should treat?
In my opinion, we should treat.
Okay. Because it's 86 in the mid portion.
9.3 in the mid portion,
Uh-huh.
and we
Have 86 in the
yeah, we will gain like 0.7.
Because you're taking all the full coronary bed
Okay.
that is related to that lesion. It does not impact only that proximal segment, it impacts the full territory.
Okay.
So that's an
So you
interpretation
think we
that we
should
do.
treat?
We think, I believe we should treat.
Okay. Okay.
Yes.
So you are the operator.
It's not invalid, the decision
Yeah.
to do
Peixinho, por favor.
the stent implant here.
Yeah.
Yeah?
Should we stop?
Yeah, no,
No. Go ahead.
go
and
ahead.
treat. Okay.
Okay, so we can go ahead and use the same wire here, okay? So we don't have to try to recross
Can
again.
you do direct stent in this, or should we prepare the lesion?
Since
Since the lesion is not severe.
Yeah, it's not that severe. There's some calcification there. I thought we could have some preparation there because there's some degree of calcium there as well.
Okay.
So we're gonna try to go with the 3.5 with 3.0 by 15 non-compliant
Caiu aqui, ó.
balloon. Just to have a good
Ó,
opening
isso
there.
precisa ficar aí, ó. Derrubaram aqui, ó.
Espera aí, espera aí, espera aí.
Trace.
And we bring it here to this RAO caudal view, where we can see the lesion here. Segura.
Put the reference.
Okay, so we are advancing here the balloon. It's a 3.0 by 15. Just to take the lesion at the very ostial location, it's a short left main here. It's about 6 millimeter by IVUS. Okay. So I'm pulling back the wire here a little bit. Okay, can go up.
Can you put on the reference?
Pode subir, por favor. Okay, so go 14, 15. It was a good open here, okay. Descend.
So are you going to cover
more
all the left
control S.
main with the stent, or
Control.
just restrict to the
Control
distal
S.
left main?
We thought about, it's a short left main, and we saw the lesion extending to the left main, so we want to cover the left main as well.
Or
And do
even
the
the
pot
ostium?
there, up to the ostium, yes. It's 6
Okay.
millimeters there.
So what size of stent you are going to?
So the size of stent that we have there, we have measured and taken, let's say, the less disease segment based on what we saw by IVUS here. We're gonna, we pick a 3.0 by 33.
So
it
you're
can
going to
go
do a
up to the
provisional
ostium.
technique.
Provisional technique, no
So if
stenting
this
plan.
circ is not okay, the result,
Yeah, we saw,
what technique you are going to choose?
it's provisional, so stenting, then optimize, do the pot, and then recross, do the kissing. Very
So if you don't,
gentle
if you don't-
implantation.
if you do not get a good result in circ, you're going to do a tap, T in protrusion, or T, or
Yeah, I don't foresee that we get a significant compromise, but if we did compromise, we try to avoid as maximum as possible to have a stent in the circumflex, because
But
the results in
I'm-
long term are not good.
I'm asking just if you need.
If you need, yes, you do a tap,
Okay.
provisional T.
Okay.
Let's go.
Stent 3 por 33, por favor.
Is there a place in nowadays to do like a? Okay.
Please. send the
No, I don't
questions.
have the slides on, but if you want to ask me.
Can you ask the questions here live? Vamos lá, stent. Definitely, as much as you can control, either primary or secondary prevention, even more important, should be a target regardless if you have a revascularization procedure or not. So yes,
What the size of the stent you are
very
using
important.
now?
So it's a 3.0 by 33, so we can cover up to the ostium, and we can be a good landing
3.0 by
zone.
33.
Yes, we can be in a good land zone here
So-
to avoid the lesion. Okay.
What view we're going to use to deploy the
Test.
stent in the ostium?
We use this view to check your position, but to deploy, if you want to pick the ostium, you need to use the LAO cranial view. That's where we're going to go
So
now.
did you measure the lesion by IVUS?
We did measure the lesion by IVUS,
So,
so that's why we're going with a relatively longer stent here.
yes, we are placing a 33 millimeter stent
Yes,
using IVUS as your reference.
using IVUS as a reference.
Now, I was asking you about the better view to position a stent in the left main, the ostial left main. Which one do you choose?
So here we use the LAO cranial view.
Uh-huh.
That's where we can see the very ostium of the left main. So you should
you
never
need-
place our ostium's left main without this view. Test.
Okay. You need to be
So-
very careful about the guiding catheter.
And sometimes you have to pull the guiding catheter
the
together.
the LED wire is distal.
Is distal. Okay. So
Okay.
to distal, we're going to
Yes.
pull a little bit here.
We need to be careful
Yeah.
to avoid perforations, to watch everything
Test.
about the wire. Now you're bringing back your stent, is that correct?
Yeah, I brought back the guiding catheter,
Yeah.
the stent, so I'm moving
guiding
everything
catheter with
together.
your left-
Test.
The guiding catheter with your left hand. Can you show the left, Ricardo's hands, both
So,
hands, please?
I like the position here. Let's take an angel here. Okay. So I think
You like that?
I like that. I think we have the ostium here. Okay. 1 millimeter
So
protruding.
you cannot miss the ostium, but you cannot either to leave the stent in the aorta.
Yes. So
It's
try to
really
be
hard
as
decision.
accurate as
Do you
possible.
think it's okay now?
I like the position. I think we are.
Do you need to check in another view, or
Yeah.
this is enough for you?
For the left main ostium, it's enough for me here.
Okay, good. That's
Okay.
the better view to position a stent in the ostial left main.
How
Sobe,
about
sobe.
distal?
Sobe, it's okay.
Yeah.
2,
Now we
4,
are
6.
inflate the balloon in
Okay.
the left main.
10,
Needs to
12.
be a short inflation,
Okay.
short time,
So we went to 12 here. Okay,
12.
okay, down.
and deflate
So now we can use the same balloon here. I'm just gonna.
without moving the balloon to check where you deploy the stent. Is that correct?
Yes.
Okay, good.
So I'm pulling now the guiding catheter
Yeah.
with my left hand, and I'm pulling the balloon just to avoid the guiding catheter to touch the struts here.
Yeah,
So
it's
I'm
very
pulling
important.
everything here. Okay,
So
so I'm out,
he-
and I'm using the same balloon here
Ricardo,
to do some
left
extra
hand.
post-dilatation, okay?
Okay.
Pode ir, subir, vai,
Now he pulling back the balloon,
vai, ok.
and we are going to up to
16.
with 16 atmosphere.
okay.
16.
Ok, down.
So you are just to optimize the result in the LAD. Is that correct?
Yes.
Okay,
So
good.
here I'm just pull the
Pull the
balloon.
stent
I'm
back,
bringing here
the
with
balloon
my
back.
left hand, very gently here,
Okay.
taking care with the wire distally.
So you need to watch
Test.
your guiding catheter.
Okay.
You don't want to touch the.
So we're
the
just going to
stent.
do a control angel here.
Okay. Good.
So we are fine. No compromise of the circumflex. So now
What is
we're
next?
going to remove, we're going to optimize the expansion of the stent in
So
the
you're going to
LED.
keep both wires,
Both wires.
CERT and LED,
Yeah.
and bring a larger balloon.
Yes, 3.5 by 20, balão 3.5 por 20.
Okay. 3.5 by 20. You're going to use this balloon to optimize the.
The
LED
LED,
stent too?
the LED stand.
Okay, LED
And then
distal.
distal.
distal
And then
part.
we leave the pot for
Uh-huh.
later.
What's the size of the left main?
About between 4.5 to 5.0.
So this is the balloon is only for the LED.
The balloon is only for the LED.
So you're going to
I'm
use a
bringing from distal
4.5
to
balloon.
proximal, exactly. I'm
Proximal
working from
to,
distal to
left main.
proximal. Yes.
So we still have 8 minutes. I think we're going to have,
Yeah, we can work here.
even with the keep the wire. So after you finish the LED optimization, I would say, You're going to keep the wires to optimize the left main?
Yes, I'll keep the wires. I just remove the circumflex when I recross if I decided to treat the circumflex.
Okay.
So I'm bringing now the balloon here. It's always good, as you mentioned, to be very
Now you're
careful
going
in
to
this
work on
position
LED
here. Okay,
with
so
the 3.5 balloon.
Bringing here, 3.5 by 20. So I can go across here very gently. And we start from distal to proximal. Põe o vis, por favor. We're going to use here the Stent vis feature in this GE machine, just to make sure we are in the right position. Pull half millimeter. Põe de novo, por favor, vis.
Perfect.
Okay.
No, just a minute, just a minute.
Oi?
Tem que tirar,
So
o,
you're
peg.
using the
Tem que tirar o peg.
stent boost? Huh?
Yeah, it's like a Stent boost or Stent vis, whatever, depending on the
vis,
system you use.
Uh-huh.
So I like the position.
Yeah.
Okay, we inside, okay. Start. Sobe. Vai a 12,
Okay. You're 12 atmospheres now.
14,
Yeah, 12,
14.
14,
16,
A 3.5 balloon.
16.
16, okay. Down.
Okay.
There's some calcium there that we're not gonna be more aggressive than this. Now I'm pulling here the balloon and I'm pulling out the
Okay.
guiding catheter. Ok, sobe. Pode a 18. 20. So I went up to 20. Okay, down. Test. Okay, so we're fine. And now we're going to go with a larger balloon to the pot.
Okay.
And o balão
Keeping the wires in the same place.
keeping the wires in the same place.
So even the circ wire.
Even the circle wire. It's a safe technique to have patency and facilitate your re-access to the side branch if you
So
need
if you
it.
have good result with this 4.5 balloon in the left main, do you think we need to work on the circ with
No, that's no
the kissing and final kissing?
definite answer about this. Some studies suggest you might have less restenosis. Some studies suggest if you now with the pot that if you have fully open, that might be okay. I tend to do it, but
Okay.
in a case like this, I don't see any compromise. Probably not do
Okay.
it. It's a good option as
Once
well.
you have a FFR wire in the LED, can you measure after you do this?
We can try to measure. Sometimes to do the equalization it's a little bit challenging, but we can try.
Uh-huh.
So I'm going here with a
Take your time,
5.0 balloon.
Uh-huh.
I have to be very
Perhaps this is going to
accurate
be the
position
final step.
test. It could be the final step, yes.
It's a 4.5 balloon.
It's a 5.0 balloon.
5.0 balloon.
Test.
It is open, Ricardo. Can you close?
Oh yeah. Test.
Okay.
Okay, so I like the position here. Go up.
So it's
10.
just proximal the bifurcation.
Yeah. 12.
So you have a 5.0 balloon
Down.
inside the coronary artery
We
in the
did the
left
pot
main.
here. Yeah.
We went up to
Grandíssimo.
12.
12 atmosphere.
And this
So
is
the balloon was fully expanded.
fully expanded.
So you're bringing back the balloon and you're going to do a
Control
test
engine.
now.
Okay.
Bring the guiding catheter. Okay, great.
So we like very much the position.
Uh-huh.
So Fausto, I think we're ready here to IVUS control. And
So it's better. Can you do FFR? While
we can do.
we are
Yeah. We
preparing
can
the-
do. Yes.
Okay.
We can try to
So
do it,
let's
yeah.
do FFR. May you have FFR in the screen, and while they are preparing the IVUS, just to save time, Ricardo. We
Yeah.
have
Segura
4
aqui, por favor.
minutes.
Tira aqui para mim. Tira aqui.
Can you do?
Yes, of course.
And after you take the balloon off, maybe you can just repeat the angel.
Yeah.
Okay, great. You have the FFR there, and you're going to equalize everything.
Yeah, we're gonna
Yeah,
try
And
to
how you're doing
here.
equalizing? Can you play the last image, Alberto, please?
Pause.
Next. Oh, you didn't.
Yeah, now we're
record?
gonna do the angel, control angel here.
Okay. So you're going to do control angel.
Pronto? Okay. So we see a fully open left
Okay,
main,
there's
ostial
some-
LAD.
Okay, there's... Okay,
I think we got the landing zone that we wanted to have it,
uh-huh.
and we can
Can
do.
you stop there?
Yeah, we can stop.
Okay, we are equalized
We're
to
gonna-
have the FFR.
Vamos conectar aqui, por favor, FFR.
Deixa o IVUS pronto aí, por favor. We are okay, we have time. We still have 3 to 4 minutes to do FFR and IVUS. Is that enough for you?
I think so, yeah.
Okay, good.
Let's try
That's
to...
a good demo.
Vamos,
That
vamos
was a good
conectar aqui, por
demonstration.
favor.
For those who came to life now, we had a lady with stable angina, with no ischemic test before the CAT lab. She had a diagnosed CAT in another
compressa,
hospital,
por favor, compressa.
and she came to us with between 50 to 60% lesion in the proximal LAD, but with a very clear
Yeah,
stable
back there.
angina. And diagnosed, the lesion seemed to us a little bit higher, about 70%. But here we did IVUS. The minimal luminal area was
Conectou?
3.1, proximal
Eu vou equalizar
LAD,
aqui, preciso
ostial
puxar.
LAD, and the FFR was 0.83. Now we are going to measure again the FFR
Não, eu
just
vou-
to see if
eu
it
vou
worked
equalizar.
what we did here.
So, Fausto, the first thing here, I need to equalize, okay?
Okay?
So I'm bringing back here. And here I need, antes eu preciso da agulha rotor aqui, por favor. Desconecta aqui.
It's in a good position there.
Yeah, I think so.
Okay?
But we need to equalize first.
So, but you're not going to place the
I'm going
guide
to go
wire
down.
register?
I'm going to go down, yeah.
Down.
But I need to equalize first.
Okay. Now equalize everything.
So,
Okay.
Just a minute.
Great. Equalize it.
not yet. They're just connecting here.
Okay.
And we should have the transition here just at the tip of the guiding catheter, okay?
Uh-huh.
Equalize?
Maybe to go down, you need to do the cranial view.
Yes. Põe na cranial, por favor. Okay, so we equalize
Okay,
here.
equalize, everything goes. Okay. Okay, maybe we have 3 more minutes, 1 extra minute or not?
Fica para você testar para mim, tá? Por favor.
Just to show the IVUS. If it's okay. Thank you very much. I appreciate it.
Yeah, sometimes the wire here, test please. It's a bit challenging, but
Okay, we are placing the guide wire exactly the same place we were before.
I'm going here in a septal here. Okay,
Okay,
so
good. Now
now
you
it's
got it.
better. I think it's a good position. Okay,
Yeah,
here?
good position.
Okay,
Just to have to align the.
Now you're going to measure. Is that correct,
yes,
Ricardo?
we're gonna measure now.
Have the IVUS ready because we have only 2 minutes, please.
Okay. Lavou, fez sigil?
It's okay.
Agora.
Okay. Let's
Okay.
see.
Stop.
Oh, I have to
Okay.
flash again.
You should wait a little bit before you do a new measure here.
Uh-huh.
I was doing
Okay.
You're
some
going
nitrate.
hyperemia here.
Let's see.
Just wait a little bit here. Yeah, you need to wait a little bit here. Yeah.
Okay, we are waiting. Not measuring yet. How many minutes do you usually wait?
At least 30 seconds to 1 minute.
Okay.
That's what we do.
So we have been waiting for
At least, yeah.
45 seconds now.
I think less. I think like 25 seconds, yeah. You need to see
1
the
minute
screen
now,
and try
1
to
minute.
and try to have this,
We have been waiting for 1 minute now.
without. Okay, so let's measure.
Let's measure.
IFR.
Let's see.
So 0.89.
89. It's
Next-
much
next
better.
one.
It was 0.83.
Yeah.
0.90. Again, measure again,
Next.
and go to IVUS, please.
Okay.
Okay. Good.
0.89.
Point
So we're
89.
gonna
So
do
you
IVUS.
did a good job. You went up from 83 to 89. Is that correct?
It is what this showing, yes.
Okay.
And we took the highest degree of
Okay. Let's go just
ischemia.
to do an IVUS run in 30 seconds, okay?
Okay. Yeah.
Take the
IVUS.
IVUS with being so careful just because we are finishing the transmission, please. So it's going to be not a very long run. We are going to be distal to the stent to see the ostial left main. Ricardo is bringing the IVUS now. Then you can have the hemodynamics now. No FFR more than the screen. We finish with the FFR. You can have only the angio in the screen, please.
Okay, so we have the IVUS here.
So the IVUS is there. Can
The
you bring the
catheter
IVUS
is
in the
out of the
screen, please?
ostium. Can we have the IVUS?
May I have the, okay, great. Thank you.
Fica
If
fazendo.
you can have the IVUS, can you bring the guiding catheter out of the
Yes, it's already
ostium?
out.
Out of the ostium?
It's already out, yes.
Okay.
Okay, pull back, please. Oh, Fausto, this is a high definition IVUS catheter, 60 megahertz.
So I think it's too distal. Can you bring it?
There's already, you see the stent here, the
Stand? Okay,
distal
good.
end of the stent.
Okay.
So it looks well opposed, you know, in this point. There's some calcification here. Can you put the larger view, please, Wagner? Larger view. Okay, so we see fully open here according to the vessel size. We optimize here with the 3.5 by 20. Went up to 20 atmospheres.
Great. The stent is well expanded. So let's
Now
see.
we should be coming close to the
Yeah.
ostium. You see some degrees of calcification here. You see the entrance of the first diagonal, which is also good opening here by angio as well. So you see the wire here coming. You see the pot makes it very well opposed and open towards the circumflex. And here we are into the left main, you know, just across. And I think we're just in a good position, taking the
perfect.
very awesome location.
That's great.
So
Great results.
we don't
Great.
feel like we should do anything else here in the circumflex.
Uh-huh.
And I'm just going to do the final control angels here.
Okay, we're going to do the final angio and we will finish the case. Do you have... Okay. Okay.
Ready?
So let's do the angio, okay, and say goodbye.
Okay. What?
Inject. Okay, great. Absolutely great. So
Let's
with
see.
this, please be close to us. Here, Ricardo, just look at the camera. So after those two cases, we treated right coronary artery in the lab 1 and now the ostial LAD in the lab 4. I congratulate you guys, our Professor Sergio Braga, and also the fellow here, it's Silvio Zampieri. He's using mask. I cannot recognize. Ricardo and Alberto. Great. Thank you, Medstream. Thank you, Samir Mehta, and all the organizers.
Thank you.
See you next Wednesday.
Thank you.
Bye-bye.
Bye bye.
Bye.